Okay, so I don't have any conflict of interest to declare. We've heard a lot about the double burden of HPV and HIV, and we know that women living with HIV are 4 to 5 times more likely to develop cervical cancer. And we know that these deaths that they suffer from are preventable. This is a quotation from Gertrude Mutharika, the First Lady of Malawi, who said that today women are surviving an HIV diagnosis only to succumb to avoidable cervical cancer. The need for concerted efforts in responding to the double burden of HIV and cervical cancer is warranted now more than ever. We need to increase the coverage of cervical cancer screening services, especially to women living with HIV. And then she went on to promote early treatment and vaccinating all eligible girls. So we need to build synergies. There's clearly a strong association between HIV and HPV. And so we need to build synergies between the response of HIV and HPV. Henny did talk about the WHO global strategies. And just to summarize them, it's vaccination. 90% of girls below the age of 15 should be vaccinated. We must screen at least 70% of women using a high-performance test, and then treat 90% of women with precancerous lesions. So each country needs to meet their own personal goals, and each country should also meet the goals of eradicating or eliminating HIV by 2030. So I'll quickly talk through the HPV vaccination program in Uganda. As you all know, we were one of the first countries to introduce the pilot vaccination rollout in 2007, 2008. But recently, the Ministry of Health did a post-immunization evaluation for various molecules, but particularly I'll concentrate on the one for HPV. We know that vaccination generally makes a huge difference in all age groups, and we need to make children and adolescents the change agents who will demand for these vaccines. We did universal vaccination in Uganda in November 2015, and it's a 2-dose regimen administered 6 months apart. The eligible population are 10-year-old girls or girls in primary 4, and we are using a mixed strategy, using health facilities, doing outreaches, and also immunizing during the Child Days events. So some of the objectives of the post-immunization evaluation were to identify the strengths and gaps of the immunization program, and also to make a recommendation to the Ministry of Health and our immunization program, but also to improve the performance of the vaccination program. The key findings rotated around looking at the cold chain management, the waste management and injection safety, vaccine wastage, and then monitoring and supervision. This is just an example of our HPV vaccination cards, and our health management information system looks at following up the TT and HPV register. In Uganda today, we don't only give TT, by the way, we give tetanus and diphtheria. So just to share with you some very not nice results, the performance of the first dose was relatively good, but what surprised all of us was the poor performance of the second dose. We had stories of parents taking away their girls from school on the days of the Child Health Plus, and we know that a girl is only fully immunized if they've gotten their second dose. In spite of Uganda adopting a 2-directional strategy, the performance of the second HPV was not good. And as you can see, there were peaks in immunization, but then the second dose went down. And throughout the year, there was poor performance, especially of the second dose. So we need to build communication strategies in order to improve our HPV vaccination. We must communicate that vaccination of adolescent girls is safe, and it should be seen as a high priority for both girls whose immunization is lacking or incomplete, but also that vaccination started during adolescence can be completed at any time during the process. These are some of the common questions parents ask and some concerns. Is the vaccine safe? What are the side effects? If I vaccinate my child, will she become more sexually active? Should I really get this vaccine for my child? Can she wait until she's older, until she's 20, until she's finished school? And then they usually ask, if somebody has HPV already, will the vaccine treat it? If you happen not to come back for the second time and the third injection, is it a problem? Should girls get their pap smears before the vaccination? Should boys be vaccinated against HPV? And in the presentation that Professor Botha did, I'm sure you parents in this room who are going to inform other parents will be able to answer those questions. So we set out to promote HPV vaccination in general. In other words, if a parent is concerned, please ensure that you inform them that there is no direct link between vaccination and early sexual activity. In fact, the girls who are vaccinated are more likely not to have early sexual activity. It's important to emphasize that the vaccine is most effective before the initiation of sexual activity, because then you reduce on the potential exposure to HPV. Please emphasize that HPV is important for cancer prevention, and there's actually a direct link between cervical cancer and HPV. Please remember that there are universal recommendations and the vaccine is efficacious. We just saw the example of Australia. In Uganda, we do offer vaccinations to adolescents, tetanus and diphtheria, HPV, hepatitis B, measles and rubella, and then the yellow fever vaccination. We are also soon starting a rollout of the COVID-19 vaccine to children and adolescents 12 years and up. So I'll quickly tell you about our Friday Adolescent Clinic, and I'd like to thank members of the Friday Adolescent Clinic who are here in this room. It was started in May 2013, and it offers a broad range of services. The clinic only opens on Friday, and right now the clinic is running, and half of us are here. So I don't know who's running the clinic, but the services are for adolescents 10 to 19. We offer comprehensive confidential care and mental health services. We offer reproductive health care, school health, nutrition, and we do immunization updates. But we also use the clinic as a training model for our postgraduate students and even the undergraduate students. And since when we opened the clinic, we've seen 7,200 unique cases, clients, and there have been 5,236 repeat visits. Most of these adolescents come in for vaccination and just to ask questions. But what is needed to develop a proper adolescent clinic? What should we do to engage adolescents better? Do we need flat TV screens, beautiful tennis courts, PlayStation games? Do we need to attract them with snacks? Actually not. All we need is confidentiality, a non-judgmental attitude, and respectful healthcare providers. We also need to build user demand. And we've done this through various ways. We recently developed an HPV Comic handbook, and we've done school outreaches, we've done skills building sessions, and we recently started the Swag Plus. So this is the HPV Comic series. I'm happy to share with you a soft copies on your WhatsApp. And then the Swag Plus is Safe Womanhood Awareness. It includes males, hence the plus. It's a health promotion campaign that is practiced by the young people themselves. They speak about immunization and safe practices in school and encourage each other to complete their vaccination series. So I'm just going to take you through a summary of recommendations for people living with HIV. This is data from a paper from Nelly Mugo in Kenya, and the summary of it is that children living with HIV were able to retain long-term antibody response following HPV immunization. However, further work is needed to define whether HIV-infected children are going to be protected from HPV acquisition with low levels of HPV antibodies. The WHO recommends 3 doses for people living with HIV. And as you heard, WHO also recommends giving 2 doses to girls aged 10 and up. So it becomes a little bit confusing for programs. And that is why, for me, the call is upon all of us to integrate HPV and HIV, to integrate the 2 of them, so that if you are managing adolescents living with HIV, they must get 3 doses and not just 2. And this same recommendation is for the US. Sorry, we lost the slides. And developing countries need to ensure that we not only vaccinate, but screen and treat, so that we can eliminate cervical cancer altogether. This is ongoing research. My colleague and I are doing SMS electronic reminders for vaccine completion in Uganda. It's an NIH-funded study. And soon one of our master's students, Dr. Sekina Hassan, is going to be looking at prevalence of HPV vaccination completion among adolescents at the JCRC clinic. Please visit our website, the Society of Adolescent Health in Uganda, for tips on how to develop your own adolescent programs, but also to see things that we've done previously in Uganda. I'd like to acknowledge my parent department at Makerere and Mulago, and staff of the Adolescent Clinic here present and those who are covering us, the Ministry of Health Uganda, Interest 2022, and MSD for supporting this conversation. Thank you very much.